Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. Such a lovely, lovely, absolutely gorgeous day here in Northeast Florida. We've been getting so much rain that it was such a pleasant, not that I'm complaining about the rain because we needed it. Of course, it's essential, but it's a beautiful day. We didn't have any rain, and I have to, before we get started, I have to say make sure that you are aware that rain breeds mosquitoes, and we need to make sure that we are aware that mosquito borne illnesses are not good for any of us. So make sure that those pots and tires and all types of things that are outside in your yard that you keep them free of water. Turn those pots upside down, and of course when you go out at night, wear long sleeve shirts and make sure you are using some type of mosquito repellent. And that's my plug, Doctors Kane and Brown, about mosquito borne illnesses, West Nile, Eastern equine encephalitis. I heard on the news the other day, Dr. Kane, that there are 30 something types of mosquitoes. Who knew? How are
Wow.
you doing this evening, Dr. Kane?
I'm doing absolutely fine. I don't know one I only know of one mosquito and they back. So I think that groups all the rest of them together. and
I know.
FYI, did rain at my office today. And
You did
another
what
health
now?
alert. It's gonna get hotter and hotter. We may reach 3-digit temperatures. So check on your neighbors. Especially the elderly neighbors like me. Check on them and make sure that they're doing okay. So, but Dr. LaRae, Dr. Brown, how are you?
I'm doing well.
Very good, very fine. It's nice to see you. Uh, I think we have some mutual, I'm not going to say mutual relatives, but I do know some people that know you.
Exactly. I heard that too.
It's a small world. Don't you both know it?
Yeah.
Definitely. Definitely.
Well, we are pleased to have Dr. LaRae Brown, a local obstetrician gynecologist here in Northeast Florida. She's going to talk about from puberty to menopause, a lifelong guide to gynecological care. If you don't know, it is Women's Health Month. And an easy way to remember that is it's always the month of Mother's Day. So it's a reminder for ladies to make sure that you're going in for those very important health screenings. And as Dr. Kane often says, that you're checking on those loved ones who are vulnerable and sometimes who might forget to do that. So, Dr. Brown, welcome. How are you doing this evening?
Thank you. Thank you. I'm doing well. I'm excited to be here to speak with both of you today.
I told Dr. Kane before Dr. when I we came on, I told Dr. Brown I've heard so much about her, and I'm so pleased to meet her for the first time in this virtual space. And Dr. Brown, I want to start out by asking you to tell us a little bit about your background and what inspired you to become an OBGYN.
Good question. Yeah, so I was speaking earlier. I am from Northeast Florida myself. I grew up in a small community in Nassau County, but I didn't have any exposure to Black physicians except for on the Cosby Show, Dr. Huxtable. So
Wow.
I also have, a large, close knit family full of very strong women and strong men. But I saw lots of sickness, illness, even in my community. And I was always interested in the science part, but more so that communication, that education. I need to make sure everyone knows how to best take care of themselves. So I saw an episode of Maternity Ward when I was like 6, and they filmed it at UF Health downtown, Shands.
Hmm.
And it was this young Black woman had triplets. I thought it was the coolest thing ever. I thought it was so awesome how you could grow a human inside of you and then the human just appear. So my whole life, when I was little, I was obsessed with animals who were pregnant. I was obsessed with women who were pregnant. I just thought that was so interesting and cool. So I went to University of Miami for undergrad, and then I came back up to University of Florida, go Gators, for medical school. Yep. And I tried to have an open mind. I was trying to just expose myself to all the specialties, but I kept being drawn to the care of women. And, over the course of my career, the novelty of delivery and surgery, that's still there. But my passion at this point, I had a mentor tell me one time that, you can only touch so many finite patients. I can only see so many patients. I can only deliver or operate on so many patients. There's physical limitation to that. But if you can use your knowledge and influence to help larger groups of people, that further carries your purpose. And I feel like, especially in these times, so many of us are marginalized regardless of status, regardless of income. There are still so many barriers to us getting the care that we need. So a champion for the health care of our women and our families. I mean, we're the basis of all those things, and especially in our community.
That's so interesting that you say that, because that is also, excuse me, Dr. Kane, what prompted us to do the podcast. Because during COVID-19, we knew that a lot of people were misinformed, just didn't understand what was going on. So that's when we started the podcast, to use it as a platform to educate people. And I couldn't believe it. I just thought, Dr. Brown, that it was just going to be during COVID-19. But Dr. Kane won't, and Tyrone won't let me stop. It's just like Dr. Kane was like, I've known him for,
100
decades.
years.
And one thing, when I got ready to retire, I think he was my he wasn't my physician anymore, but he asked me, okay, what are you going to do now? You can't just sit around and do anything after you retire. So I have accepted the challenge, and I applaud you for going outside of the walls of your practice, really educating, of course, within the practice, but also going out in the community, having these conversations. So thank you for that. Dr. Kane, you're going to say something?
And you said part of it, and that is, I concur with Dr. Brown completely. There's only so much of us we can share in person, okay, and touch it. And we only got two hands, and they can't be all over the place. Well, sometimes maybe, but anyway, they can't be all over the place with these two hands. So what we most certainly do, and what we have tried to do, is to try to fill in that gap. And we try to find as many physicians to come on, because we like diversity in opinions. Right. Most of the time I'm agreeing with my specialists anyway, but we still like diversity in opinions about how people do things. We like to educate patients in terms of an audience, patients in the audience, in terms of how to visit your doctor, regardless of what kind of doctor it is. What things you need to start focusing on, concentrating on. So our show is what we try to do in this show, in this podcast, is to bring attention to people, to need to be educated by people, especially people that look like you. Not saying they're the only people, but especially people look like you. So, Dr. Brown, I go right along with what you said. And it just so happened that Dr. Cliff Huxtable was an obstetrician, huh? Okay. Yeah. I digress.
That's funny. So, Dr. Brown, why is it so important to talk about women's gynecological care across the life spectrum, from puberty through menopause?
Yeah, it's particularly important because, it's laid out in the disparities that we can see in statistics, from maternal mortality and morbidity, even to GYN care and, screening for cervical cancer or breast cancer or ovarian cancer. Our population is still disparate diagnoses and delays in treatment and just the outcomes related to that. So I feel that, within our culture, there's certain things we do. We might not talk about everything, we might not share everything. And we just might not have been exposed to the standard of care with regards to preventative maintenance and screening. So it is a matter of life and death, essentially, because we know that preventative care saves lives. So I think that through education and awareness of, just the names of our body parts, the potential that all of those body parts have to become dysfunctional or to bear disease. And then, like Dr. Kane mentioned, just how do you communicate that? How can you advocate for yourself in spaces where you might not share a lived experience with the provider? It might not be a concordant provider, but you still can access care and you still can advocate yourself as long as you're empowered with the knowledge to know what's abnormal versus what is normal.
And I'd like to add, advocate for yourself and your loved ones, because some of you may have those aunts or mothers, and then we go the other direction, those kids, your children, whether or not they're nieces, nephews, or your own children, that the more educated you are about your health, the better you can help and assist others.
Right.
Yeah, I agree. I remember, Dr. Brown, when I first had the dreaded pap smear when I was a younger lady, a girl, if you will. So when should a young person first visit a gynecologist, and what can they expect?
It's a good question. So I definitely recommend that everyone across the board by the age of 21 sees an OBGYN. Now, if you're having abnormalities before that time or need to access birth control or have any symptoms or questions, I also welcome people in earlier than that for problems, but also to establish a relationship. Many people are terrified of me because of that pelvic exam, but sometimes we can just meet and we can prepare for that pelvic exam for years to come if it's not indicated at that time. And sometimes that verbal communication, that establishing you're in a safe place. I'm not going to tell your mama, but let me tell you about your body before a 15-year-old boy does. That is a crucial conversation. So I have lots of patients who bring their children to me at 12, 13 to begin a conversation about body awareness, about the things that, you will be exposed to as a teenager. And I always feel like it's better to hear it from a trusted source. Because as you guys know, these teenagers and TikTok and all that, there's a lot of misinformation, even within the young group.
Speaking of misinformation, I used to. It's one time I feel like 50% of my practice was gynecology. Okay, never OB, because I delivered those babies I had to in residency. But 50% of my practice was gynecology. But I advocated that because I just felt like you guys know so much more than I'll ever know, and it's hard to correct misinformation to an extent. When people receive it, it's very difficult to dispel it. So I'd rather them get it correctly, at least when it comes to a professional, because I don't want to be the one to give it incorrectly, and then they ride on the word of Dr. Kane that this is the way it is. So I'd rather them see people that specialize in what they do, and that's what you guys are specialists and primary care.
Yeah. Oh, listen, I'm sorry. I kind of stepped away, and I think about when you talked about social media. I was yesterday, as just so coincidental, I saw a commercial about a speculum that's out on the market, and it's saying order one and take it to your OBGYN. I could not imagine. That's almost like, I can't imagine taking it. It was meant for, made by a woman for women, and I'm just like, really? I really can't imagine bringing that speculum in, and the fact that you would use it.
But that's kind of born out of just decades and decades of medical trauma. Like even you today, you remember your first pelvic exam vividly, and it was a negative experience. So if you didn't have the education or the forethought to be like, what, this is something necessary, I do need to come back. I see patients who have a bad experience and they don't come back for years. And then also, not only just in the exam, just in the way we communicate with patients, because dispelling those myths, Dr. Kane, that's hard. Because if somebody's grandma told them this is how it is, it's hard for me to unravel that. But with that cultural sensitivity,
Mm-hmm.
Yes,
Like you can do that. You can honor the lived experience of somebody's grandmother and give them the objective data that they will need to make the best decision.
Yeah.
absolutely. I agree, concur, totally.
Mhm.
Speaking of which, I think the first conversation that moms typically have with their girls is related to their menstrual cycle. So, what are some common menstrual concerns in teens, and when should parents seek medical advice? Because that's what happened with me. The reason that, by the way, Dr. Brown, I don't mind being personal on this
Yeah.
because if it helps someone, I'm a health educator by trade. So if it can help someone else, I don't mind sharing. So, what are those common menstrual concerns in teens?
Yeah, well, most young girls begin having their first period between the ages of 10 and 15. So sometimes when you're outside of that age range, that can be troubling, whether your period is delayed in onset or if you start super early.
Mhm.
Just for practical reasons, an 8-year-old and 9-year-old, sometimes it can be difficult to keep up with menstrual hygiene and cycle tracking. So the age and the maturity level of the child plays a huge role into how their period is begun. I also see a lot of mental anguish or just a lot of um, instability with regards to expectations of people's period. So again, that kind of goes back to what your mama or your aunt or your grandma told you to expect. So I really try to
Mhm.
give some normalcy to what a true period should be. And then if it deviates from that, you have to let us know. So age 10 to 15 is when it should start. Your period should last between 3 to 7 days, and it should not be painful to the note of being debilitating. So if you would rather miss school, or if you have to miss school, or if you're bleeding heavily where you're changing your pads frequently, that warrants extra attention. And when most young girls start their first periods, it's just overwhelming. It can even
Mhm.
take a year before things become regular or what their normal should be. So supporting them through that development, but also giving them the guardrails to know what is normal, what is expected from a period.
I tell you what, the products have evolved over the years because Lord knows when I started in back in the prehistoric days, um, the products have certainly changed and are a bit more user friendly. I think about even the when we talk about the lifespan as, and when you mentioned a few minutes ago, sometimes some girls find out or learn stuff they think from the
Right,
young boys. Like,
right,
no, that's not your trusted source of information regarding your gynecological care
right,
Let
or
me
right.
step
needs.
in. Let me at least say this. I'm the father of 5 girls,
Hmm.
and mom used to work hard. Mom was a hard worker. She'd be at work. We trade, as you know, for being a physician,
Uh-huh.
and a physician parent. We could trade off anytime who kept who, when, where, and how.
Yeah.
And boy, being a physician, I'm a little bit more up to speed than some of the other non-physician fathers,
Right.
but it's not easy. It
Yes.
is not easy to have a conversation. And some of those fathers may be the only parent in those kids' life.
Right.
And because they may be the ones that are taking care of them, but they also should be, those fathers need to be educated. And I'm hoping there are some men watching this podcast
Mhm.
because that is not an easy subject to discuss, even though I had plenty of practice before my youngins or during my youngins' uh,
Mhm. Mhm. Yeah.
exposure to menstrual cycles. It
Mhm.
is not an easy subject for men. I can only imagine. I can't imagine, I guess, what women do and say to their girls on
Yeah.
these conversations. I know I have conversations. When I was doing that whole GYN thing, a
Uh-huh.
lot of parents did bring the girls to me to talk about STDs mostly.
Right.
Okay. As far as menstrual cycles and stuff of that nature, most of them were covered, but I still investigated, yada, yada, yada.
Mhm.
But my main point I want to get across is that men need to hear this conversation. They
Yeah.
need to hear it.
Exactly, exactly. Because I mean, it's an entire cultural experience. If you've watched your mom suffer through bad periods and that was normalized, you might not be able to pass that along to your daughters or your friends or even your wife. So I think that that education for the family and also demystifying, talks about GYN care. I feel like that kind of gets us into trouble sometimes too if we don't talk about it and you get that wrong source, specifically surrounding like body awareness, sexual abuse, all of those more tricky subjects. Sometimes it's easier to harm or neglect or do something very bad to a young child if they have no awareness that that's even something harmful.
And primary care physicians, please stay alert to that, because sometimes that we're not paying attention. I don't, these days I don't ask as many questions as Dr. Brown does, but I'm still always trying to pay attention to what these young ladies may be going through.
Right.
And that if I can be of any assistance, trying to make sure they're not abused, that they don't have any STDs, because if they're sexually active, we're gonna check. We're gonna get that green card a good run, and my green card is the check for the STDs, is what I call it, and give them an awareness of where they stand as it relates to certain STDs.
Yep.
If you're just tuning in, we're talking to Dr. Lorraine Brown from Puberty to Menopause, a lifelong guide to gynecological care. Ask questions. This is your time. You can be behind this camera and just post us a question, and we'll certainly get that out there. Dr. Brown, I think about, when you were talking, I was thinking about my younger days as a health educator, and I had people, to my colleagues, they would bring their daughters to me to talk about reproductive sexual health because that was the conversation they felt uncomfortable about having, and the birth control options. Have birth control options changed much over the years, or do you find that most people still rely on birth control pills?
Yeah, I think birth control, just the acceptance of the different long acting reversible methods has, just become a little bit more popular because of their flexibility. And overall, I feel like, especially this younger generation, they are more aware of the long term health benefits and almost want to go to a non hormonal or lower hormonal way to protect themselves. So I think that also a good thing that the young generation can access is GYN care and especially STD treatment and contraception, like through telemedicine, or they don't have to physically go into the office and hide it from their mom. They can get it online, or that there are other safe places to easily obtain contraception, at least for now. So those are all pluses that we have going for us right this moment. But in regards to the different routes that we can provide contraception, birth control pills are still going to be a standard, but there are numerous types in with regards to extended dosing, how much hormone is in them. But the more popular long acting reversible contraceptives like the IUDs and the arm implants like the Nexplanon, they kind of take away the user error that teenagers sometimes can be troubled with, and they don't cause any long-term implications with fertility. So we and they're reversible. So those have risen in popularity, not just among teenagers, but among busy working women, because it's easy to forget a pill. So those have become more popular. Then you always have your old stalwarts, the patch, the shot, the NuvaRing, which is a vaginal contraceptive. But those long-acting reversible contraceptives have really changed the game to give people a window of, sexual freedom without the user error with pills.
Years ago, when I was at the health department early in my career, I'll never forget, I had just started, and I did say that early in my career. An old public health nurse said, she was, giving me some advice, make sure you're clear, because she told a young lady, now you put that pack of pills on the nightstand drawer by your bed so you won't forget to take them. And so when she came back pregnant, she said, you didn't take the pills? She said, you told me to put them on the nightstand drawer.
Right. Exactly.
And she never took them. So you really have to be very clear with people take one a day, pick it up off, take one a day. You really have to. So you actually mentioned some methods, quite frankly, being an old timer, that I
Mhm.
had not even heard of, Dr. Brown, in terms of the, so when I see ladies with the thing, I call it the thing on the back of their arm, then more than likely that's a patch, a birth control patch.
Yep, more than likely. Yep, those are very popular for people who don't want to do anything orally, and you can leave that patch on for a little while, so that helps with adherence. But yeah,
Yes.
that flexibility that teenagers or even older women need to protect them against pregnancy is something that is still evolving and like I said, becoming way more popular.
I didn't know that IUDs was still, people are still interested in getting those, so that's surprising.
Yeah, yeah. So they've come a long way in regards to both the size, so that helps with insertion,
Mhm.
and the delivery of the hormones that you can get from the hormonal IUDs. But there's also a non-hormonal IUD that's made of copper. So some people who want to go a more natural route, they choose that. It's a very effective means of contraception, and for that busy person, whether you're 15 or 30, just placing it and not having to think about it works out well.
So, speaking of the reproductive years, how can women manage painful periods, fibroids, or irregular cycles during their reproductive years?
Yeah, so when we're talking about our 20 to 30-year-olds, that's the peak reproductive age. And even before you get that diagnosis of fibroids or hormonal changes or heavy bleeding, you need to make sure you advocate for yourself and get in to get that correct diagnosis. So before you're even planning your family, having an accurate diagnosis is very helpful. It leads to less frustration along their fertility journey, but just puts you in a better position to have a healthier, safer pregnancy. So having an annual exam with a trusted provider who can detect body changes, detect anatomic changes. Fibroids are very common in our communities. Probably 7 to 8 out of every 10 people, Black people, may have a fibroid sometime in their life. So, depending on the size, shape, depending on how your body personally takes that fibroid with regards to pain or bleeding, that's important to elicit before you even talk about getting pregnant. And then with regards to painful cycles, there are certain conditions that can definitely debilitate you with regards to pain. Not every period shouldn't have to be a bad period where you have to
Yeah.
suffer through. One of the most common is endometriosis, and that's pretty common in our community as well. That can cause some infertility issues, but just the debilitating nature taking you out of work or school and the mental impact that has on you can be very hard for some people. So the key to success is bringing those complaints, those signs, symptoms to someone you trust and getting a thorough evaluation to make sure that number one, you're able to manage those problems, whatever we diagnose well, but also in
Mhm.
preparation for your fertility journey.
Yeah, and I think about people who have, they didn't even know that they had issues until they tried to get pregnant, got married and tried to get pregnant, and then unfortunately found out that they can't get pregnant. So, what advice would you give to people pre-pregnancy, though, to get to know, when you talk about get to know your body, know what things might not be normal that
Mhm.
could potentially impact your ability to get pregnant?
Excellent question. So, in one important point I want to make is, within our population these days, we're more educated. We're delaying childbearing for a lot of women. And as we all know, as you age, your fertility declines. So I never encourage my patients like, please rush out and get pregnant right now, even if you're not ready, just because you're getting older. We don't want to do that. But we
Mm-hmm.
also want to set up in a very caring environment the realistic nature of aging, the realistic nature that our ovaries have a finite number of eggs and they're going to dwindle. So having that conversation early, even in their 20s, you know what? By 30 to 35, you should have an awareness of your fertility journey. We actually have a blood test now called the anti-Mullerian hormone, or AMH, that can give us an assessment of your ovarian reserve. So I can draw that blood test. If I have a 25-year-old patient, I can draw that blood test and say, you know what? I got a number, and this number looks like you have the adequate number of eggs for your age. And we can do that serially just to kind of keep that in the back of our head. But also, if you detect changes in pain or bleeding, a thorough physical exam with a pelvic exam, but also imaging, a simple pelvic ultrasound, not really super painful, but and it's not very long or expensive, but that can kind of give us a visualization of exactly what's going on inside. And then just having a provider where you can run the course of your journey. So, you start in your 20s, you make sure you have the expectation for what a normal cycle is. They have a thorough family history. What does your moms and your sisters go through? A physician who can comprehensively know what your best game plan will be for the future.
Yeah. Yeah, and also, Dr. Brown, let's talk about responsible sexual behavior, though, because if you are not responsible during those formative years, it may come back to haunt you when you've decided to settle down and you want to have a family. Talk a little bit about that.
Yeah, and that's one of the dangers of, that readily accessible STI diagnosis and treatment. Sometimes there's a perception like, oh, we can treat that. You might can treat that and clear the bacteria for now, but there can be lifelong ramifications that occur from that exposure, particularly of like chlamydia and gonorrhea. Those are very common STDs, very easily treated, and if you are not treated in a timely fashion, they can actually predispose you to infertility. It changes the way your fallopian tubes work. So that can be something. It also can predispose you to something way more serious called pelvic inflammatory disease. And sometimes my younger patients may have had chlamydia or had pelvic inflammatory disease, in college. And then now they're 35 and they're like, I need to get pregnant. And I may find out that their tubes are damaged, or I may find out that they have chronic inflammation inside their womb when, that could have been prevented by those exposures earlier in life. So those things can definitely linger.
Yeah, and
And
the
one of
conversations that you need to have to tell folks to use protection and forget what he says. Dr. Brown, I used to do when I was teaching classes, I used to do demonstrations and I heard it all, Dr. Kane, guys talking about the condom wasn't big enough for them. And I would literally make a fist and put a condom over my fist like, yeah, right. So
Yeah.
don't believe him. Don't believe him. It can protect yourself
Mhm.
because you don't want to later on in life, not just talking about STIs, but also unwanted or unexpected pregnancies as well. Dr. Kane, were you going to say something?
Yeah, I just want to make sure I highlighted the fact that women may demonstrate different symptoms about STIs, STDs, and
Mhm.
depending on how old you are,
Right.
uh, may demonstrate different symptoms compared to men. We, for lack of better description, it might be a little graphic,
Mhm.
but we kind of urinate out the same
Mhm.
organ that we
Right.
have sex with.
Right.
And so if that gets irritated or inflamed or injured in any form or fashion, we kind of feel it.
Mhm.
Because women do not,
Right.
okay, particularly these younger girls,
Mhm.
they can have an STD, an STI, whichever way you want to call it. They
Mhm.
can have that and not know it. Meanwhile, it's steady doing damage, working away, doing what it needs to do. And
Right.
by the time you realize that you have one, whether it's because some guy came along and told you that he gave it to you,
Mhm.
or your physician, like Dr. Brown, is examining you and realizes that you've got all kind of either scar tissue or something along that line associated with long-term STD, you may not realize. It's one of the reasons I believe in, and I'm not just the only reason, but definitely women, young ladies, you may be protected against pregnancy, but you are not necessarily protected against STIs or STDs. And
Yeah.
so you must protect yourself.
Right.
You need to choose your partners wisely. When I mentioned green card earlier, what it basically was saying, I was looking at HIV, herpes, chlamydia, gonorrhea, and
Syphilis.
syphilis.
Yes.
I think I pretty much covered most of them, but it's about 6 of them. Even trichomonas, because
Right.
it may give you a hint as to what else is going on.
Mm-hmm.
So when those things I say get checked.
Mm-hmm.
You got if you clear and everything's good, your partner's green card need to look just like yours.
Right.
Okay. And even then, you still should be wearing or using condoms, because we know how some people are. They can't be satisfied with one woman or one man.
Right.
And it's just too much out there. So protect yourself, protect your future family.
Yep.
By making sure you cover yourself for STIs, STDs, so on and so on and so on. There was one question about, does Medicaid cover gynecological services for the 10 to 13-year-old? I'm pretty sure they do. Okay, I don't think that's an issue at all.
Mm-hmm.
Medicaid, regular insurance, you name it. We should and we could make it happen to make sure you're taken care of. So don't worry about whether or not you're covered for a particular entity. Present it to us and let us make that determination for you.
I remember Dr. Brown and Dr. Kane years ago, again, with the almost 4 decades in public health, Dr. Brown. I'll never forget, years ago, my colleague told me about a patient that was so young, they had to tell her at the same time she was pregnant and HIV positive.
Exactly.
And so, and had not even had her first period. And so, how devastating is that, right? To tell a young person that. And so we really need to make sure we have conversations. And when you don't know how to have the conversations, that's when you can find, and by the way, not all females like going, sorry, Dr. Kane, not like going to a male doctor to have those conversations. So it's nice that we have female physicians where you can be comfortable and feel comfortable. And I have to give a shout out, by the way, to my former colleagues. I see them on Facebook who are still having those conversations, educating women about STIs. Brandy Williamson, Terencia Shiloh, Stephanie Reeves, they're still pounding the pavement, having those conversations with folks about responsible sexual behavior, because we all remember during our careers as young educators, seeing how so many young women are exposed to those STIs early on, or those women who are infected with a disease that they thought they were in when they thought they were in a monogamous relationship. So it's just so important that we have the conversation. And Dr. Kane, I don't know why people are uncomfortable about asking a man, have you gotten tested?
Right.
Or an STI like HIV, or are you sleeping with other people? Do you sleep with men? I don't know why people are uncomfortable about having those real conversations that we need to have with one another.
Not me. I ask them all. I go after it to try to figure out what's going on, because I let them know I'm here to help you. And I am highly what's the word I'm looking for? I'm an advocate, very high advocate of women seeing women for gynecology, because they experience, we talk about cultural sensitivity. We should talk also about, what's the word I'm looking for? Sexual sensitivity, male versus
gender sensitivity. Yeah,
gender sensitivity. I recognize that that's out there. My girls, they still ask me, but I try to encourage them to go see their gynecologists and their women gynecologists especially. And they're all in tune, including their wife, in tune with a female gynecologist, especially a Black female gynecologist. I am not anti-white. Okay? That's not what this show is about. Sure. What we're about is just trying to connect with people to put them in a space where they're most comfortable dealing with. And if you're more comfortable dealing, because I have some people don't want to see Black, whatever, but if that's where you're most comfortable at, fine. I just want to get you the help that you need to have to make the right decisions, okay, for yourself and your family. So I have no problem a woman not want me to do a pelvic. As a matter of fact, I will probably say it before they do.
Yeah.
To go
Dr.
get them
Brown,
to go see a
Dr.
gynecologist.
Brown, what are those key screenings as we talk about the lifespan and that women should have? You know, you talked about at age 21 going to see the um, GYN for maybe that first pap test, but let's talk about the other screenings a woman should have throughout her life.
Yeah. So I just want to reiterate to the callers again. I think sometimes people get confused about what a pap test is. The pap test is just something that's performed and the pelvic exam. So I have a patient say, I went to the ER and they did a pap. That would never happen. You
Nope.
had a pelvic exam. A pelvic exam is when we examine all the structures, the GYN structures. The pap test is a swab that we check for cancer of the cervix, the opening to the womb. So that's a very important distinction. We start that at 21, no matter if you've been having sex for 10 years, don't matter. We start that at 21. And then we can repeat it every 3 to 5 years at a maximum. There needs to be shared decision making depending on the patient's symptoms, and you can have that discussion with your provider. And then we think that we should discontinue around the age of 65. But again, that is very dependent on the individual patient risk factors. And I'm such a strong proponent in shared decision making. Other screening tests, HPV testing. So we do that with the pap test. So human papilloma virus, it's the virus that predisposes you to cervical cancer. It can also cause warts and some other issues for the lower risk strains. But for the high risk strains that can make you at higher risk for cervical cancer, when you get to 30 years old, or if you're under 30 and have abnormal paps, we check your HPV status so we can kind of give you a better game plan of, should we do a biopsy? Do we need to do surgery? So that's just an adjunct to the pap testing. And that's done every time you have a pap test when you're above 30. Mammograms. So breast cancer, again, one of those disparate conditions in our community. We feel that you should start at 40. If you are higher risk, a strong family history, lumpy breast, another cancer in your body, you may have the opportunity to get a mammogram screening earlier. And then at minimum, every 1 to 2 years, depending on your individual risk factors. Colon cancer screening, yet another disease we're more disproportionately afflicted with. Now, the recommendation is to start colon cancer screening at age 40. The gold standard is a colonoscopy, which I know is very scary for lots of people for numerous reasons. So they even have the Cologuard, which is an at-home test. You take a stool sample and you're able to send that away. You can't do that until you're 50. But at least that provides another alternative so people can get the screening that they need. Very quickly, bone density scanning. So weak bones or osteoporosis or osteopenia. As we get older, and especially women, as we lose some of our hormones, it accelerates bone loss. And if you are petite or have a small frame or have a family history of fractures or been exposed to steroids for a long time, there's certain things that can make you at higher risk to have a break. So we do a scan of your bones and we're able to tell you generally around age 65, but earlier if you have certain risk factors. We talked about the STDs. Everybody under 25, every single year should be screened for STDs. And I would suggest it's offered to everybody every year.
I do.
Yeah, exactly. I offer it to everybody, even people who are like, nah, I haven't done anything. Let's just check, because you never know. Because when was the last time you were checked? And I also think there's so much stigma with HIV and herpes. No one looks like they have those diseases. So you have to prove it. Like when you're having that conversation before you initiate your first sexual encounter with a new person, of course, you wouldn't be attracted to someone who looked sick. So make them prove it to you that they're not sick by those tests. Yep, exactly. Syphilis was rampant in this area. Absolutely rampant. Had a huge impact on the babies that were born. Because like you said, sometimes we're not going to the doctor until we need to, until you're pregnant.
Mm-hmm,
And then I'm telling you, it has affected your baby. So it's a big important thing to maybe have that annual screening just to double check, even if you're monogamous. You never know where the exposure may have occurred.
yeah.
I tell people quickly 2 things. Tell them quickly. You can get syphilis shaking a hand. So you
Right.
know, if it's depending on the circumstances.
Yes.
But the other part I tell them is that you're coming in with certain things, certain situations. If it's my mama, I'm going to check them for STD.
Right.
Okay. You know, I feel confident about what my mom doing. I say, but if you want to be a good, efficient provider, you
Right.
need to check. You know, and even though I might expect it to come out negative,
Mm-hmm.
never hurts to check because you never know how wrong you can be with certain individuals. Let me
Exactly.
ask one quick question. I just want to be sure I got a good understanding. No PAP until you're 21, whether you're sexually active or not, or do you?
Yep. Excellent question. So even if you have been sexually active since 12 years old, no PAP, but PAP doesn't equal pelvic exam. So we
Right.
think
No,
that,
I got that.
uh-huh. So
You
yeah,
know,
so
I
that,
just looking at HPV, and some people may or may not get the vaccine.
right.
You know, and of course, my generation grew up. My generation was informed that we should, you know, if they're sexually active, go ahead and do the pap smear to
That's
make
what I
sure that
always was told. Mm-hmm.
you know, there's no cancer, yada yada yada.
Mhm.
So I just want to be sure I got the answer right to the question.
Yep. Yep, that's the party line. So the thing is that we also don't want to overreact or do unnecessary procedures to patients, because HPV, probably about 7 out of 10 of us will be exposed to that. And even much higher when you're 18, 19, and 20. So that's why we want to vaccinate before they even start having sex. But if they miss the vaccination, or sometimes, you're still going to gain that exposure, the natural course of being exposed to HPV and developing cervical changes takes years.
Years, right.
So even if you start having sex at 12 and are exposed to lots of things, it's unlikely that you'll have cervical cancer. But again, I would look at their cervix. If they're severely high risk sexual behavior, like I've seen some issues with child abuse and sex trafficking, I'm looking, and I might even do a PAP, because that might be a unique situation. General population 21 for that initial, and just like I said, 65 is the upper limit. But I got some 90-year-olds that if they got diagnosed with cervical cancer, they would want treatment. So that's my little barrier with regards to when you should discontinue things. If patients are willing to pursue treatment for whatever I'm screening for, we need to be screening for it.
My look at it winds up being, you know, the introduction, the Viagra era,
Yes.
and where these old men bringing diseases to old women, older women. And
Yep.
so I went through that whole period where we were trying to figure out, okay, why is it that highest STD rate we're seeing in Florida winds up being 55 and older,
Yep.
and so on and so on and so on. So nobody, and for me, nobody that go for mama, sister, son, daughter,
Right.
whatever, is beyond reproach as far as you sure you don't have an STD?
Right.
Nobody.
Right.
Dr. Kane, you aging yourself. We say STI nowadays.
Okay.
You know, I
But
know when
listeners may not recognize STI. That's why I say STD and STI.
old listeners, right? Yeah, because when I first started, Dr. Brown, at the health department in 1982, it was the VD clinic. So, and Tyrone, I see your little smart comment about female cougars. I want to move on before we end the conversation and talk about perimenopause and menopause. What are some of the earliest signs of perimenopause, and how do they differ from menopause?
Got it. Yeah. So very quickly, our ovaries were born with good, strong ovaries, all the eggs. As we get older, our ovaries age. So as our ovaries age, they produce less hormones. When you go through menopause, that means that your ovaries aren't making any more hormones. So leading up to that, every day your ovaries are trying to die. And if you ask a perimenopausal or a menopausal woman how they feel, it's peaks and valleys. So you start to get irregular periods. So it's not like clockwork anymore. You may skip periods, have long delays, or your periods may be heavier. They may be more frequent, but just that connection between your brain to your ovaries to your GYN organs is disrupted because your ovaries are aging. You can also get hot flashes and night sweats. We call those vasomotor symptoms. So again, the ovaries communicate with this little area of the brain that causes that thermal regulation. So you're throwing the covers off at night, then you're chilly, or in the day, you're just at church and then all of a sudden you break out into a profuse sweat. So those are those vasomotor changes. You also get metabolic changes. I mentioned earlier the bone changes that you can get as your hormones wane. You also can get changes in your cardiovascular health as your hormones wane. And then the mental health or the mental fog, that aspect should not be denied at all. You know, the root word for hysterectomy or uterus is hyster, but that also is the root word for hysteria. So in the old days, when people started going through perimenopause and menopause, people thought they were crazy. And many women, I talked to Tyrone about this earlier, like there's a whole social media craze about perimenopause and menopause now. So there's way more awareness. But many women just feel crazy. You're hot, you're sweaty, you're irritable, your period is a mess. And sometimes if you go to individual doctors for all the individual problems, you might not put it together that this could be due to those hormonal swings. So the average age of menopause, so that's 1 year with no period. And after that, you're postmenopausal. But even 10 to 15 years leading up to that, so I have people in their late 30s and definitely in their 40s who are experiencing this menopausal transition where their ovarian function is just waning. So all of the balance that they had before just becomes more unbalanced.
So what about hormone replacement therapy? How do people make the decision of whether or not they should or should not? And what are some things they should consider?
Yeah, so I'm just gonna be honest. My family is extremely country. Like I am natural Nancy. I don't want any medicine unless I really need it. So coming from that lived experience, sometimes it's an interesting conversation that I have to have with people. But at the baseline, I would say if your symptoms are debilitating you, if you are not sleeping and you're driving off the road in the morning, or you can't pay attention in meetings, or you're falling asleep at church, or if your periods are just a mess and you're having accidents and you can't predict them and they're getting painful, if the symptoms are debilitating you, then maybe we should investigate what we should do about that. I hear it commonly like, oh, my grandma got through this, or they got through this in the old days and they didn't need anything. They didn't have the tools or resources we have now to support you. And sometimes it can be unpredictable how long this will last or just how it will affect individuals. So there are many options, from natural supplements to just behavior modification therapy. There are things we can do to help you through it. But hormone replacement therapy is the gold standard because, like I said, as the ovary is dying, you might want to replace some of the hormones that you're losing from the ovary. And if you have a good physician who can reassure you and examine all your individual risk and can really support you through that, it is a safe alternative for some people if they reach that stage where, you know what, I have to do something, or my husband's going to be so annoyed with me, or my kids are so annoyed with me. It can become debilitating for some people.
So speaking of older women, what do you say to older women who still like to roll in the sack but have a problem with dryness?
Good question. So first, I say that it's not you and it's probably not your husband. It's one of those impacts from losing the hormones from your ovaries. That vaginal lubrication comes from the estrogen that you used to produce. So as you lose that, you lose lubrication, but also the lining of your vagina becomes thin and is more traumatized. And you want to avoid sex because it's so painful. So it's that vicious cycle. So you can use lubricants. Oil-based lubricants are always best. That's always the first line because I'm natural Nancy. Try that. But if that doesn't work, there are medications. There's an oral medicine that kind of controls how your brain processes things a little bit better. And it's non-hormonal. It's called Osphena. That's a choice. But there's also estrogen that you can deliver directly to the vagina. Not a lot of that gets into your bloodstream. It's safer than HRT, like the oral or the patch. It's just delivered to the vagina. You control how much you give. You control how often you dose it. And that is a very effective way to treat vaginal dryness due to menopause.
Well, what type of gel? I know there are a lot of gels on the market. I'm sorry, Dr. Kane. What kind of gel did you say?
So actually, this is going to sound kind of crazy, but some of the best gels are natural oils. So like olive oil. Yep. I've seen people use Crisco. I don't know if I would recommend that.
Put you a separate bottle. Don't go in the kitchen and then go in the bedroom. Put your bottle in the bedroom.
Not the oil on the back of the stove. Make sure it's still on the bottom. just a little bit
Well,
too. But yeah, those are all good choices. I would stay away from the water-based lubricants because the water-based lubricants actually dry you out more. So those would be okay. But Astroglide isn't all bad. I mean, you got to play around with it to see what works for you. Because remember, it's also a spectrum. You know, sometimes you may just have mild vaginal dryness, but sometimes it can be very severe, and that changes. There's also hyaluronic acid. You can buy that kind of over the counter
Wow.
as an option as well.
Are there any medications, blood pressure or otherwise, that might cause that, also interfere or cause that dryness? And I'm just asking, I don't know.
Yeah, typically not, but typically some of those blood pressure medicines might have more to do with the menopause or like vasomotor symptoms, like hot flashes, night sweats, sleep
Mhm.
disturbances, but not necessarily the vaginal dryness.
How does stress, diet, or lifestyle choices impact reproductive health over time?
So something very unique to us is the idea of toxic stress. And
Mhm.
this is one of my little personal interests because I don't think sometimes we realize just the chronic nature of all the things that are on our plate. So most of us work, most of us have families, most of us are around or hear issues with racism, politics, caring for elderly parents. There's a lot on the plate of many of us. And sometimes over time, it's just been so interwoven into our DNA, into the way we interact with our families, that being stressed is the nature of the baseline. Like this is normal. That's what I do. And
Mhm.
that causes us to delay our access to care, to put ourselves on the back burner. But it also changes our body. It raises our blood pressure. It causes our heart to beat faster. If I'm the
Mhm.
only Black person in the room for every meeting, and even though that's what I'm used to, there's a different expectation for me in a situation where I would be more comfortable. And that's my baseline every single day. I have 3 Black sons. If they're driving around and I'm always worried about them getting pulled over, there's always a baseline of a higher level of stress and anxiety. And that causes weathering on our body, and that changes our response to illnesses and aging. So I think that definitely plays a role into why we may be more disparate when it comes to those diagnoses. And diet and exercise as well. You know, there are certain stigmas in our community surrounding that. Most Black women don't exercise because we don't want to mess up our hair. It's not an issue of vanity, it's an issue of cost, it's an issue of time. And the only way we can kind of break through that is normalize safe, healthy ways to exercise and balance that. I can't go in the room and say, work out, I don't care about your hair. That's not going to fly. We're going to have to figure out culturally ways to support us with regards to exercise and diet too. Every event we have in the Black community, there's food, funerals, baby showers, birthday parties, and a lot of it. And it's very good. We have to normalize what normal portions look like. We have to normalize, moderation for the things we really desire. But coming at it from a lived experience, coming at it from, you know what, these are healthy changes that we all do together. Coming from my own examples of my own family and sharing that with patients just helps it flow a little bit easier.
What are some common misconceptions or myths or misinformation you hear from patients that you'd like to clear up? Anything that, like, where are they getting this? I mean,
So one is going to be that there's an obsession with people cleaning their vagina and doing things to their vaginas. So there's a whole marketing. There's yoni steams. There's all kind of products in the store, online,
yeah.
about just ways to have your vagina be more balanced and smell better
Mhm.
and all those things. And while there is room for certain hygiene practices that are within the realm of normalcy, that don't predispose you to other bacteria or other infections, we should really be careful, and we should maybe trust our bodies a little bit more that the vagina is a self-cleaning organ. The
Mhm.
confidence from a patient will come through having an exam, being reassured that you don't have an STD or an active infection, and then just finding a healthy balance to what a normal vagina should look like, what it should smell like. So that's one big misconception that I see.
And if you could give one piece of advice to women in each decade of life, teens, 30s, 50s, whatever, what would it be?
Yeah, so I would, for my teenagers, I would really say that this is the time that you should be confident and aware of your body. You know your body best. So you should learn the most about it that you can to protect it. You only get one body. So you should learn how to protect it the safest way possible. 20s to 30s, when you're kind of that reproductive prime, you should have the guardrails up to know what is normal and what is not.
Yeah.
Painful periods, heavy periods, other hormonal metabolic changes, acne, abnormal hair growth. You should have those guardrails up that when you're climbing that career ladder or meeting your husband, you know that, you know what, I think my reproductive health is on track because I'm not having these worrisome symptoms.
Mm-hmm. Mm-hmm.
40s, that's the crucial sandwich generation. So we're taking care of our aging parents, and we got teenagers and kids, and we may feel crazy because this is the perimenopausal transition. So again, that education and awareness, that preparation for what's to come. I realize that things are changing and I need to be prepared. And I also need to have my guardrails up for if these symptoms become debilitating, how can I access help? What supplements can I use? What support do I need? And then for my postmenopause, 50s to 60s, I don't ever want my older patients to become complacent. The more birthdays we get, the more likely we are to get cancer. So I never tell my patients, not only because I love seeing them, I never tell them stop seeing me. Even if you don't need a pap, even if I did a hysterectomy, you might have your ovaries left behind. You still have a vagina. You still have intimate areas of your body that might warrant an examination and that could be life-saving if I take a look or I do an exam. So just don't write off any GYN concern just because you're older. Like you said,
Yeah.
still want to have intercourse. You may have had a family history of GYN cancer. There are still relevant topics that you can discuss with an OBGYN or a trusted primary care physician.
Dr. Brown, you have been absolutely awesome. So amazing. Thank you so much. We are at we're at the close of our podcast, and we'd like to give our guests an opportunity to share their final thoughts. Anything you'd like to add now that maybe we didn't touch on, or if you'd like to add how any of our listeners would like to keep in touch with you. I see Tyrone already asked you that, but what are your final thoughts as we close out tonight's discussion?
Yeah, I just said this just a few minutes ago. Like, you know your body better than anyone, so if you go to one physician and you're advocating for yourself and explaining how you're feeling or explaining your concerns, if you don't get the answer that you need, find another physician. This can be a matter of life and death. It's no different than if I go to the shoe store and they don't greet me or help me, I find another shoe store. This is a very, very important message. I need everyone to trust your body. And if you have that education and awareness, and even if it's burgeoning, even if you're learning more about your body and need that clarification, it's so important to have an excellent relationship with, the medical providers that you can build your trust with.
Thank you. Thank you. So awesome. Dr. Kane, what are your final thoughts?
I agree with 100%. First of all, thank you, Dr. Brown. Been excellent with your view on things and your advice to patients and physicians. You've been excellent at doing that. I would so thank you very much for coming on our program. I do think that if women are going to let me back up. I think the advice that you gave in terms of them feeling comfortable talking with their physician, whether it's primary care, whether it's obstetric gynecologist, for which many times you guys are the primary care, depending on the pregnancy, yada, 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 that they need to talk with a physician one, being comfortable with, and two, that provides you all the information at their disposal to help you make your decision. And if you're not content with a physician, doesn't mean that he or she is a bad physician. Right. It just means you guys are not connecting. So find somebody else that you can connect with and be able to relay your concerns and have an appreciation for the answer that they may give you. A trusted person that you will eventually grow to trust, whether it's obstetrics, gynecology, or woman, whatever physician it is that you're looking for. So, and the epigenetics of stress can't be overstressed.
Yeah.
Excuse the pun. Because the epigenetics, and for people, for listeners, epigenetics is just things that happen to you as a result of the amount of stress that you, especially Black women, through all the slavery, they're raising the master's kids, they're raising their own kids. Right. All the things that they had to go through, the epigenetics of it is beginning to affect us even in this day and time. And even though some of us are aware of it, and a lot are not. So I think what we want to do, and the return of menopause is something we didn't get a chance to talk about it, but I do like the idea and Dr. Brown, you can come back later because we knew that this was going to be a short version of everything a woman needs to know. But one of the things that really I think about, I get asked is, why am I going through, I've been through, to these 70-some-year-old women, is I went through menopause already and went away. All of a sudden it's coming back, and they're trying to figure out why. And I give them some answers sometime as to why I think, nothing proven scientifically, whether or not there are hormones in our foods and they have something to do with it, and so on and so on. But the one thing I do stress with them is that women, estrogen is a drug that you've been with since you that you've been with most of your life, and especially once you became in that reproductive area. Yeah. And just like Wesley Snipes, not Wesley Snipes, Samuel L. Jackson was in that movie with him and Wesley Snipes when Samuel L. Jackson was on the couch going through withdrawal. That's kind of like what we see with women going through withdrawal from estrogen. Yes. You've had estrogen since you was, now you mentioned 8 and 10, but back in my days, we were looking at 12, 13, 14. Now we're looking at 8 and 10. I don't know what happened. That's another subject. But they start having that withdrawal symptoms, and damn if it don't mimic withdrawal from heroin and any other addictive drug, because you've been with it for all your life.
Exactly.
So with that, I said thank you very much. There's a lot. We're going to bring you back because there's so much more to talk about. Definitely. And Ms. Turner, you led an excellent discussion. I never could have done it myself. But thank you very much.
Thank you. And Dr. Brown, I have you to know my mom popped in. She doesn't usually come in she was awesome. She was awesome. But so thank you for sharing your valuable insights on the journey of gynecological care from puberty to menopause. Your guidance reminds us how essential it is for women to understand their bodies, advocate for their health, and seek care that supports every stage of life. To our listeners, remember, your health is not just about reacting to problems, but about staying informed, getting regular checkups, and making decisions that empower you. Whether you're a parent guiding a teen, a woman navigating hormonal changes, or someone embracing post-menopausal wellness, your voice and well-being matters. If you found this conversation helpful, share it with a friend, follow us on Facebook, subscribe to our YouTube channel, and of course, tune in next week as we continue the discussion on Pause for the Truth for a new topic that's going to be quite interesting, different from tonight, but nonetheless, please subscribe to our YouTube channel and remember to share this very informative podcast with others. Thank you again, Dr. Brown. Have a good evening.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.